Good evening, everyone, and thanks very much for the invitation and opportunity to speak. I've been asked to cover the topic of where does hospital in the home fit in treating urinary sepsis. I don't have any disclosures. So in terms of the burden of disease of urinary tract infection, it's certainly high. Urinary tract infection is the most common human bacterial infection, and in Australia, it accounts for 1.2% of all GP presentations, along with 76,000 hospitalizations for urine or kidney infections in 2017-18. It's important when we're discussing urinary tract infections to define the different types of urinary tract infection. And when people refer to UTI, what they commonly are referring to is cystitis or lower tract infection, infection of the bladder. And this is when people have urinary symptoms, pain on urination, frequency of urination, occasionally lower abdominal pain, and they're feeling a bit off, but in general are not very unwell, rarely febrile, rarely septic, and not bacteremic. However, when there's transition of bacteria up the urinary tract to the kidney via the ureters, this is when people develop more complicated urinary tract infections. Pyelonephritis, urinary sepsis, upper tract infection are all referring to this entity. And these patients are unwell, often with fevers, rigors, flank pain, and occasionally bacteremic as well. And an entity that is oft forgotten in male patients is prostatitis, which can exist in acute and chronic forms. And the acute form often behaves much like pyelonephritis, with patients feeling fairly unwell, occasionally being septic, but also having prostatic symptoms of affected urine flow and pain in that area. So I thought that I'd discuss treatment in general of these different types of urinary tract infection. And the first thing when approaching the therapy for urinary tract infection is to ask whether treatment is indicated at all. Growth of bacteria from a urinary specimen does not equal urinary tract infection. It needs to be accompanied by symptoms. And the screening for and treatment of asymptomatic bacteria is not recommended except in specific populations, those being pregnant women or patients who are undergoing elective urological procedures. For acute cystitis or lower tract infection, symptomatic management is important with analgesia and sometimes urinary alkalinizing agents, although it's important not to use these concurrently with nitrofurantoin or quinolones. And the antimicrobial therapy is often empiric because of the lack of culture results at the time of its institution, and often fairly brief, 3 to 5 days for women, 7 days for men, invariably of an oral agent, with trimethoprim, nitrofurantoin, and cefalexin being some of the most common. Acute pyelonephritis requires a different management pathway, and the choice here is often between intravenous and oral therapy. And intravenous therapy is suggested for patients with persistent fever, systemic symptoms, sepsis, or an inability to tolerate oral therapy. Importantly, non-severe pyelonephritis can be managed with appropriate oral antimicrobials. However, some of the antimicrobials used for lower tract infections, namely nitrofurantoin, fosfomycin, and norfloxacin, are not recommended for pyelonephritis as they don't achieve adequate concentrations in kidney tissue. For patients who require intravenous therapy, first-line therapy is gentamicin and amoxicillin or ampicillin, and second-line therapy is ceftriaxone or cefotaxime if gentamicin is contraindicated. The recommended treatment duration is 10 to 14 days with a switch to oral therapy once the patient's clinically stable. And there is some limited data that suggests maybe 7 days of a quinolone is adequate for pyelonephritis. Suggesting that oral therapy is adequate for pyelonephritis is perhaps slightly controversial, depending on how unwell the patient is, but it's not something that lacks an evidence base by any means. And this study from 1991 is, I think, a nice demonstration of how patients with pyelonephritis can be effectively managed on oral therapy. They looked at patients presenting to an emergency department where they monitored them for 12 hours, giving them a couple of doses of IV antibiotics before discharging them to the community. And as you can see, a large number of their patients were successfully discharged to the community, and on their follow-up data, many were successfully treated. Even in more recent times and in the era of antimicrobial resistance, oral therapy is still appropriate for the management of acute pyelonephritis. And this Korean study from a few years ago, again, quite nicely demonstrated this. These Kaplan-Meier curves are looking at the probability of patients on oral therapy in the dotted red line or intravenous therapy, the solid black line, experiencing recurrence or being free of recurrence. And as you can see, the two sort of performed reasonably similarly. Treatment of prostatitis is fairly similar to pyelonephritis, with non-severe prostatitis being managed with oral therapy for a couple of weeks. There's the additional consideration of prostatic penetration with your antimicrobials, and there's favourable data for quinolones and trimethoprim. Severe acute prostatitis should be managed initially with intravenous antibiotics, and again, a change to oral therapy when clinically stable, and with a slightly longer recommended total duration of 4 weeks. Chronic prostatitis can be managed with oral therapy. In terms of the microbiology of urinary tract infections, E. coli far and away is the most common pathogen, accounting for 75 to 90% of urinary tract infections. But other Enterobacterales species such as Klebsiella and Proteus are also implicated, along with Enterococci, Staph saprophyticus. It's important to remember that the microbiological spectrum is broader in patients with recent antimicrobial exposure, healthcare contact, or urinary tract instrumentation or catheterization. But with regards to the microbiology, this is really what we experience and struggle with increasingly in managing not just urinary tract infections, but really a wide range of bacterial infections, and that's antimicrobial resistance. What we're looking at here is some disc diffusion susceptibility testing, where on the left you can see that the antimicrobial discs that have been placed have cleared the area of the bacteria that's been plated out. On the right, those discs are not doing quite such a good job because of antimicrobial resistance in that bacteria. And this is some national data from the AURA report, just looking at the rates of resistance in E. coli in blood and urine isolates, blood on the left, urine on the right. As you can see, in 2018-19, about 12% of E. coli isolates from blood were ceftriaxone resistant, bordered in red. And on the right, you know, for urine specimens, that rate is slightly lower, but still not insignificant. And what we're looking at here, I guess, is using the ceftriaxone resistance as a surrogate marker for the production of an extended spectrum beta-lactamase, or ESBL. And this is, again, from the AURA report, which looks at the trends in resistance over time. And again, bordered in red, you can see the change in ceftriaxone resistance in E. coli over the past sort of decade. And, you know, it's a concerning and consistent trend. There are a number of well-documented risk factors for MDR, multi-drug resistant infection, and these include recent stay in hospital or long-term care facility overseas in countries with a high prevalence of MDR gram-negatives, or in an Australian facility with a known outbreak. Recent overseas travel to an area with a high prevalence of MDR gram-negative bacteria, particularly if there was associated antibiotic use or medical care. Previous colonization or infection with MDR gram-negatives, particularly if it was recent or associated with the current episode of care. Frequent stays or a current prolonged stay in a hospital with a high prevalence of MDR gram-negative bacteria, or residence in an aged care facility with a high prevalence of MDR gram-negatives. And the impact of resistance on therapy for UTIs is that, you know, these people might experience failure of empiric therapy, which leads to representation to primary care or to hospital. For cystitis and non-severe prostatitis, there is increasingly a requirement for less commonly prescribed therapy, quinolones, fosfomycin, agents that prescribers are perhaps not as familiar with. And rarely for cystitis and non-severe prostatitis, there's no appropriate oral option. For upper tract infections, there's a requirement for agents that may be broad spectrum, expensive, or associated with higher rates of toxicity. And sometimes there's a lack of appropriate oral agent for step-down therapy, leading to an extended intravenous course. So now getting to the question that was posed, which is where does hospital in the home fit in treating urinary sepsis? I think really it's two questions, which is where does it fit in managing susceptible organisms, and where does it fit in managing multi-drug resistant organisms? And for susceptible organisms, I'd suggest that the role of hospital in the home is limited. For cystitis and lower tract infection, there are essentially no indications because these conditions can be effectively managed with oral therapy. Acute pyelonephritis is perhaps a slightly more controversial topic. I guess there's two opportunities for hospital in the home in this in the course of these patients' infection. One is admission to HIS, from the emergency department or at diagnosis for empiric IV therapy, which is often ceftriaxone. But I guess one of the issues here is that if patients warrant intravenous therapy, they're often unwell patients, septic patients, and a percentage of these patients will be bacteremic as well. And so often the people who require intravenous therapy are not the people who I'm particularly comfortable sending home. I think they at least warrant a period of monitoring as an inpatient. Another issue is that, the rates of multi-drug resistant organisms are increasing, as we saw, and in some centres, the rates of ceftriaxone non-susceptible isolates in urinary tract infections is, around 10%. So there will be a percentage of patients in whom the empiric therapy that's instituted is inappropriate. A minor point is that, giving intravenous ceftriaxone really represents second-line therapy for acute pyelonephritis. It's a minor point, but there is a lack of enterococcal cover and higher rates of C. diff infection from third-generation cephalosporins compared to a combination like ampicillin and gentamicin. Most significantly, I guess, we know that oral therapy is efficacious and recommended for managing non-severe pyelonephritis. So if you're happy for the patient to go home, then oftentimes oral therapy is appropriate for that patient. An exception here is patients living in residential aged care facilities in whom management at their care facility may be preferable to bring them into hospital. The other occasionally requested use for hospital in the home in acute pyelonephritis is for continuation therapy after a brief hospital admission. But again, a lot of the time oral therapy is very appropriate for these patients if they're well enough to go home. And there's good quality evidence for the efficacy of oral continuation therapy for urinary sepsis after a brief IV course. This slide is just to show that even for multi-drug resistant organisms or ESBL producing organisms and acute cystitis, there still are often a number of oral therapy choices that are appropriate, including, nitrofurantoin, Cipro, norfloxacin, fosfomycin, Bactrim, amoxicillin, clavulanate, if it is susceptible. And this is some data from a group at my institution. Ollie's one of the ID physicians there who looked at the susceptibility patterns of ceftriaxone non-susceptible E. coli in bloodstream isolates. So not urinary isolates, but probably fairly comparable. And they found that 40%-ish of these isolates were susceptible to Cipro and Bactrim, but significantly 96%, almost all of them were susceptible to fosfomycin. And so, as I said, there are a number of options for acute cystitis. However, when we are talking about upper tract infections, the choices do start to thin out a little bit. If we remove the agents that we've already discussed as being inappropriate for treating pyelonephritis, as well as Augmentin, which also does not have good evidence for treating pyelonephritis when the organism is MDR. We're really left just with Cipro and Bactrim. And when we look back at that graph, only a certain percentage of our isolates are going to be able to be treated by those agents. And that's when we start thinking more about these agents, carbapenems, which are the standard of care for severe infections caused by ESBL producing organisms. And ertapenem is really, a hospital in the home workhorse for managing these sort of infections. It's easily used antibiotic. It's daily administration. It's usually well tolerated. Important to note that it's not active against Pseudomonas, as well as the fact that you can't extrapolate the ertapenem susceptibility from the meropenem susceptibility for these organisms. So you do need to request it specifically from the microbiology lab. On the flip side, ertapenem is expensive. It costs $50 to $100 per day just for the antibiotic, and you do require intravenous access to administer it. At our institution, we try to avoid the use of a PICC line for courses less than 14 days if possible. And the other issue, I guess, is that there's no clearly established optimal duration of therapy for this condition. But there's certainly a lot of evidence that supports the use of ertapenem, both in an inpatient and outpatient setting for managing ESBL urinary tract infections. With regards to meropenem on hospital in the home, again, a contentious issue and not an agent that we use routinely by any means, but meropenem does achieve good levels in the urinary tract, and occasionally for patients with urinary tract infections in whom there are no other options, we have used meropenem on hospital in the home. With regards to other agents, beta-lactam, beta-lactamase inhibitors, piperacillin tazobactam, look, it's generally not recommended for the treatment of ESBL producing organisms. The potential exception there is urinary tract infection, and it may be used for UTI if there are no other options, but logistically it is more difficult than ertapenem in a hospital in the home setting. It's an infuser, you need a PICC line, etc. Ceftazidime avibactam is a newer agent. It's broad spectrum, it's expensive, but it does have a role in highly resistant and carbapenem resistant infections. It can be very difficult to administer on hospital in the home, but renal impairment does allow for BD dosing, which can make things easier. Aztreonam, amonobactam, is another agent that can be administered on hospital in the home that maintains activity against a variety of multi-drug resistant organisms, as do aminoglycosides. However, they certainly have their toxicities, and the duration of therapy that's required for some of these conditions makes them a less palatable option. There's a couple of novel agents, cefidoricol and plasmamycin, which may represent therapeutic options going forward. But there's a lack of data as well as a lack of access to these agents in Australia at the moment. So I guess I just wanted to leave you with these questions, which are things that I think about when I'm assessing patients for hospital in the home with urinary tract infections, which, first and foremost is this patient well enough to go home? Because if they are, then, oral therapy is likely to be appropriate, as we discussed. Is intravenous antibiotic therapy necessary? Is the same line of thinking. The likelihood of a resistant organism is very important to consider, whether you're discharging them or not with regards to what you select for empiric therapy. And then once you know the susceptibility of your organism, identifying whether there is an appropriate agent that can be given on HIF. And checking the renal function to see whether you can get around issues with administration can sometimes be a loophole, and discussing with an infectious diseases physician or your microbiology lab or microbiologist can be very useful in terms of releasing susceptibilities that may not be on the initial report, as well as doing additional testing where it can be done. And then considering what duration is required and how best to administer that duration of therapy. So thanks very much. I'll leave it there, and happy to take any questions during the Q&A later. Thanks very much.